All right, good morning and welcome everybody to Friday Chalk Talk. Today we are joined by Lisa, who's one of our two palliative care fellows here at Advocate Aurora. She graduated from medical school 21 years ago and has made a transition from a previous career in pediatrics now to palliative care. Lisa will be talking with us about chemotherapy-induced peripheral neuropathy. The format for today is the first half will be a presentation. The second half will be open for discussion. So with that, Lisa, I hand the stage over to you.
Hi, I just want to say first, thank you for letting me do this talk and have this opportunity for me to learn more about chemotherapy-induced peripheral neuropathy. I see this a lot in my Tuesday clinics, and I'm really interested to know what other people have to say about this at the end of this talk. So what is chemotherapy-induced peripheral neuropathy? It's one of the most frequent side effects caused by anti-neoplastic agents, with a prevalence anywhere between 19% to over 85%. It's a group of neuromuscular symptoms that result from damage to peripheral nerve fibers, which include the motor nerves, sensory nerves, and autonomic nerves. CIPN constitutes a major challenge for both cancer patients as well as their healthcare providers, especially because there is really no single effective method of preventing or even treating CIPN. Peripheral nerves that are damaged are either the sensory nerves, the motor nerves, or autonomic nerves. With the sensory nerve damage, your patient might complain of tingling, numbness, and/or pain. Motor symptom complaints include things like foot drop, wrist drop, difficulty with fine motor skills, such as buttoning a shirt or holding a pen. Autonomic symptoms may include diarrhea, constipation, difficulty swallowing, sexual dysfunction. So not everyone who has cancer and goes on chemotherapy develops CIPN. They found there's some risk factors for those who will develop CIPN. These risk factors include if you already had problems with fatigue or anxiety or depression. These are the strongest predictors of who will develop CIPN. Also, if there's a previous history of chemotherapy, pre-existing neuropathies, advanced age, obesity, alcohol use, kidney or liver insufficiencies. You can also, before starting chemotherapy, test for some inflammatory markers. So if you have increased interferon, gamma, or interleukin 1 beta, if these are increased, that's a good predictor that you can or may get CIPN. And which chemo drugs are known to cause this? They are vinca alkaloids, taxanes, platinum-derived compounds, protease inhibitors, monoclonal antibodies, aromatase inhibitors, thalidomides, analidomides, ecabebilone, interferon alpha. So this chart just shows some platinum-derived compounds. And you can see that oxaliplatin, and this is the drug that my patient D was on, can cause both an acute and chronic neuropathy. The acute process can begin during the drug infusion and include cold-induced abnormal sensations of the hands, feet, throat, and perioral area. The chronic form is a dose-dependent sensory neuropathy that is painful numbness of hands and feet. It can also cause sensory ataxia with gait problems. Remember how patient D fell because he couldn't feel his feet? Paclitaxin, which is a taxane, is used to treat advanced cancers of ovaries, breast, non-small cell lung cancer, and Kaposi sarcoma. As you can see under the recovery section, the side effect can last several months, or it can persist long after the chemotherapy has stopped. Toxicity may occur either with a high single dose or after cumulative exposures. Recent studies put the prevalence of CIPN at approximately 68.1% when measured in the first month after chemotherapy, 60% at 3 months, and 30% at or after 6 months. So treatments. Notice there's a question mark. There is some non-pharmacological prevention that people have tried. I just wanted to talk a little bit about cryotherapy. So there was a prospective trial that included 44 patients. These patients wore frozen flexible socks and gloves on their dominant hand and feet for 15 minutes before Paclitaxin administration to 15 minutes after the infusion was done. So it was basically a total of about 90 minutes. The control was a non-dominant hand or feet. And when the treatment dose reached 960 milligrams per meter squared, they assessed for the CIPN symptoms. And 25 of these patients reached a cumulative dose of 960, and 11 patients received even higher doses. So the results look pretty favorable. 97.8% of treated hands with cryotherapy had detectable tactile deterioration, compared with 80.6% of untreated hands. And 25% of treated feet with cryotherapy had evidence of tactile deterioration as study endpoint, versus 63.9% of untreated feet. So unfortunately, even though this publication seems to be in support of cryotherapy, there's been 8 other studies referenced in the American Society of Clinical Oncology 2021, where the authors failed to demonstrate any statistical significance. So if you want to use this therapy, it would be up to you, but there's really no studies. There's not enough studies to prove statistical significance. So that was non-pharmacological. This chart shows pharmacological options. I think many of us have used gabapentine, and gabapentine, which is in the middle of this chart, has moderate evidence. The risks and the benefits is kind of weak evidence for CIPN. But again, a lot of people do use this drug. What I think most of us use is opioids: morphine, oxycodone, hydromorphone, fentanyl patch. The evidence here is moderate, and sometimes it's the only medication to provide relief. But as we all know, CIPN, these symptoms can be resistant to even to a nice dose of opioids, and often we have to increase the dose. The good thing, not the good thing, but there are predictable side effects of opioids. Constipation, we give a laxative. We know how to treat these side effects. But what I do want to talk about in this chart is something called Duloxetine, the only drug to have RCT evidence of proven benefit. As I've been seeing in my clinic, opioid seems to be the go-to treatment for this debilitating pain, which is great, but it's very nice to have this option of duloxetine. And I just wanted to show you the study. So there was a multi-center randomized double-blinded crossover trial involving 231 patients with taxane or platinum-associated CIPN. These patients were randomly assigned to receive duloxetine 30 milligrams daily for 1 week, then 60 milligrams daily for 4 weeks, or a placebo for 5 weeks, followed by a washout period, then a crossover to opposite arm. So the results, patients who received duloxetine as initial therapy experienced a mean decrease in average pain of 1.06 compared with 0.34 for those receiving placebo. 59% of those who received duloxetine experienced decrease in pain, which is awesome. 38% of those who received placebo experienced decrease in pain. And adverse effects, fatigue, nauseousness, and there was a dropout rate of 12%. So again, duloxetine is the only drug with RCT evidence of benefit for CIPN. Study participants were breast and GI malignancies, and they complained of grade 1 or higher sensory neuropathy, and they complained of chemotherapy-induced pain greater than 4 out of 10, and 3 or more months after treatment completion they had pain. And there was like a subgroup analysis that suggested duloxetine may work better for those patients who were on oxaliplatin versus paclitaxin. So there's also, as my patient D used, there's topical lidocaine, and this topical lidocaine 5% patches. And so what about topical treatments? These are good to be used as adjunct therapy. So in combination with something else, like patient D, he used Percocet plus topical lidocaine and topical diabetic cream. You have to leave the topical lidocaine on for 24 hours. It can be applied to feet under the socks. It can take up to 4 weeks to work. And there's really no major studies that found any conclusive evidence that this is something that should be used, but there is some hearsay that it works. And there's individual studies indicate that it is effective for relief of pain. It's just no good overall quality randomized controlled studies to support the use of topical lidocaine. And then what about topical gabapentine? 20 of 23 benefited with pain scores falling from 8.2 to 5.6 at 1 month, and 11 of 23 achieving a clinically meaningful 30% reduction in pain. Typical side effects associated with PO gabapentine, like sedation, fatigue, and edema, are minimal because this is topical, not PO. And this is kind of cool. The application, when you put it on topically, it's equivalent, even with a large area, putting it on is equivalent to about only 100 milligrams a day of gabapentine. And we all have patients that have been on PO gabapentine a lot more than 100 milligrams a day. And that's it. So again, I'm a fellow, and this is my first year as a fellow in palliative care. And this topic is very interesting to me, as mostly because I have patients on Tuesday who I'm trying to help them deal with this problem. So if anybody has any advice or recommendations that they use to treat their patients and you want to share it, that'd be awesome.
All right. Thank you, Lisa.
Thank you, Marty.
Yeah. Well, we give people a moment or two to come up with a question or a story to share. I wanted to build on sort of 3 things that I was taking some notes on when you were talking. So Duloxetine, right? That is our first line treatment. It's the drug we have with the most evidence, but even that shows really modest improvement, and we really feel unequipped. Whenever we're dealing with a medication in palliative care, I think it's helpful for us to advise patients on what sort of side effects they might anticipate. So usually when I'm using duloxetine, I tend to see GI upset, some nausea, which is going to impact people's ability to get nutrition sometimes. I also see some sedation, similar to how you might see with some of the TCAs, but usually these SNRIs are better tolerated. And the other thing I think to know about this medication is that the manufacturer doesn't recommend it be used in people with end-stage renal disease. It tends to accumulate metabolites and itself, and it's not dialyzable, so you can't just remove it easily. And the second thing I wanted to add is sometimes I get asked, well, if there's some evidence that duloxetine might help treat it, what about using it prophylactically? Maybe it can be neuroprotective. And there are a few studies out there that have looked at the SNRIs, though I think it's on venlafaxine and not duloxetine. And those have concluded conflicting evidence. So I know in the most recent 2014 Cochrane review, there really isn't enough evidence to support SNRIs or really any of the antidepressants as preventative.
Thanks, Marty.
Yeah, absolutely. So we open up the floor. If anybody has any questions, thoughts, please. Tom, I see that you unmuted.
Yeah, I'll share a great presentation. It's a great reminder. Many times I forget the medications in the context that you shared. But I'll tell you some couple of very brief stories. Many cases with peripheral neuropathy come to geriatrics, nothing sticks. Like no matter what is going on, no matter what medication I give them, and I start getting first line, second line, third line. And then there's other cases where they're incredibly mild. And when I talk to them about the side effects, they say, I have the symptom, I don't want the medication. So once I start talking about falling and other like osteoporosis. Another scenario in the hospital is very commonly falls. Like I get consulted, they're like on 14 meds, 5 of them are for neuropathy. And the other story in the clinic is I try to take people off medications and they go to rheumatology, they go to primary care. The next thing I know, like instead of having, like either they add it on and they add 2 more, 3 more medications. So definitely a compulsion to medicate. And last thought is ketamine. Ketamine is a mystery for me a little bit with morphine sparing, but also using it topically could be a consideration. Thank you for presenting.
Hi, Lisa, it's Sandy. Good job. Hi, I see a lot of this obviously in our palliative care oncology clinic. Just a couple comments. The issue with your case and hearing someone say to him methadone is addicting. We've had a number of cases recently where where patients go look at methadone or they hear from the pharmacist or somebody say, you can't take that, that's going to cause respiratory depression. And it's the same thing kind of with duloxetine, which is I'd be very clear with them that when you look this up, you're going to see that this is an antidepressant, but we're using it for your peripheral neuropathy because if they see it's an antidepressant, it often causes, they think there's a stigma about depression and that we're really trying to get around the door and try to treat their depression really instead of their pain. So you have to, I would recommend very up close information at the beginning. And the last thing is, in one of my previous jobs, we did have a compounding pharmacist and they did wonderful things with topical gabapentine and it was wonderful, but you have to have a compounding pharmacist for some of those things. It was all anecdotal response, but most people did a great job with it. Also, those things are not often covered by insurance because they're quite expensive. So, but there are good options if you have the compounding pharmacist available. But thank you, it was really good information.
Oh, thank you, Sandy. That was good information on your part too. I appreciate it.
All right, everybody. Well, happy Friday. Enjoy the wonderful weekend coming up.
Thank you. Bye, everybody. Happy Thanksgiving too.
Bye.
Bye.